Good afternoon. Welcome to Health Talks, a production by Arizona State University College of Health Solutions. As a reminder, this meeting is being recorded for future broadcasts. If you have questions that you would like to ask of our panelists, please input them in the Q&A box that is right at the middle of your screen, and we will collect those questions and bring those to the panelists. At this time, please welcome Dr. Scott Leischow with the College of Health Solutions.
Great, thank you so much, Marcus, and good afternoon to everybody, and thank you for joining us for the ASU College of Health Solutions Health Talk on COVID-19. A pandemic like this one, or even worse, has been anticipated for many years, and hopefully this experience will serve to remind us that we need to improve the science and the ability to translate the science into practice and policy more effectively to improve population health. That is, in fact, the mission of the College of Health Solutions at ASU. As Arizona prepares for a likely dramatic increase in COVID-19 cases, hospitalizations, and deaths, testing to verify exposure to COVID-19 in Arizona, which is fundamental to understanding its spread and improving treatment options, has been challenged by too few test kits. In most cases, getting tested requires a doctor's referral. There have been private sources for testing, and the Mayo Clinic and Banner Health and Meridi Medical have testing options for those with a doctor's referral. And today is the first day that ASU is testing its assessment and testing procedures, and that'll be discussed shortly. Exploring these issues and how COVID-19 has become pandemic and a national health emergency are the co-leaders of the ASU College of Health Solutions COVID-19 translational team. Dr. David Sklar is an emergency physician and professor in the ASU College of Health Solutions and senior advisor to the University Provost in health policy and health professions education. He has previously worked on the hantavirus outbreak and is working on ASU's efforts to test for COVID-19. Dr. Matthew Scotch is an associate professor of biomedical informatics in the ASU College of Health Solutions and an assistant director of the Biodesign Center for Environmental Health Engineering. His research includes the integration, analysis, and presentation of viral genetics for public health and animal health surveillance, and he's also working on ASU's efforts to test for COVID-19. Dr. Brad Doebbeling is an MD and professor in the College of Health Solutions, focusing on the science of healthcare delivery and biomedical informatics. He has training and expertise in infectious disease and clinical epidemiology, and his work is dedicated to redesigning healthcare delivery and development of novel technologies, especially for high-cost, high-need patients. So our first presentation will be by Dr. Sklar. So please take it away, Dr. Sklar, and thank you.
Well, thank you very much, Scott. And can I have the first slide?
And by it's about to pop up.
Great. So the title here is just a reminder that there are various non-human hosts that have contributed to our various epidemics over the years. And we're going to talk a little bit about why that is and how that has occurred, and give us some insights into how the current epidemic occurred and perhaps what we can do about it. Next slide. So as I mentioned, there's a long history of zoonotic epidemics, and these epidemics have also found their way into our literature. So next slide. For example, plague, which was really a terrible scourge in the Middle Ages and involved rats, fleas, and the bacteria Pastorella pestis, now known as Yersinia pestis, a gram-negative rod that created a whole host of death. Some people estimate as many as a third of the world population died related to plague. Next slide. So zoonotic epidemics require a host that's usually some kind of either a animal, usually, and it could be more than one animal. In other words, there may even be an intermediate host, and I'll talk a little bit about that. And then an organism that has certain characteristics, and those characteristics are really important. They have to do with contagion, they have to do with severity, and then they have to do with generality. And I'm going to go into that in just a bit. Next slide. So these are some of the recent epidemics and some of the intermediate or hosts, some of the initial hosts that carried those organisms. And so we have, for example, the Ebola, which many of you probably are familiar with, that came from bats, and there may have been other intermediate hosts, other primates perhaps. And then we have, I think, MERS and SARS that have involved bats, camels, bird flu that probably many of you have heard of, and bird flu, so, and swine flu. So all of these are hosts that transferred organisms, some of them quite close to the current coronavirus that we now are dealing with, and caused epidemics in the past. Next slide. So here's generally what we need to understand about these epidemics. And this is somewhat common for all of the epidemics in a sense. And what we need to know is that there has to be a host species, and that host species becomes the reservoir for that particular either virus or bacterium. And then we have to understand how that reservoir species, again, it could be the bat, or it could be pig or bird or something like that. How does it come into contact with human? And it may be that there's even an intermediate host, so that the bat may have contact with a chimp or something like that, or there could be a horse involved. But through that secondary host, that may be part of what creates the generalism of the organism. The generalism meaning that it changes in such a way that it now is able to attack humans. And then the next thing we need to understand is what happens to humans after the exposure to that infection. And that's what we're just learning about in the COVID-19 virus epidemic, is what does happen to human. And I'll go into that. We also have to understand the bacteria or virus, which, as I have mentioned, is usually develops generalist characteristics. Generalist means that it's not just restricted to one particular animal or one particular species, but is able to live and proliferate and infect other animals, other species. And sometimes these infections can be very serious, like, for example, rabies is very serious. Salmonella is another very serious infection, but very few of them become epidemics. And to become an epidemic, it depends upon both the contagion, or how well it is able to spread, and then severity. So how serious is this? What is the morbidity and mortality of the particular organism? Next slide. And this slide helps illustrate that. So we can see that as you go across on the x-axis, we have the increased contagion. So over at one extreme, we have measles, very contagious. And then back at the other end of that x-axis, we have less contagious things, still contagious, but not as much. And then we have severity on the y-axis. And the particular area that we're interested in is in the kind of pinkish square or pinkish rectangle, which, as we can see, its contagion is around about like the SARS, and its severity is a little bit less, but still quite significant, sort of like the Spanish flu. And anyway, you can see if you go further down on the y-axis, we have the common cold. Its contagion is probably somewhat similar to what we have with the coronavirus, but severity is not great at all. We don't like it, but people generally don't die from common cold. Okay, next slide. And here we can just see some comparisons. We can see how the COVID infection typically can be spread on average to 2.5 people. And then compare that to some of the other infections that we've recently dealt with, such as SARS or MERS, that are more spread more than the COVID. But still, the COVID is, if we, under normal circumstances, if we aren't taking action to keep from spreading this, it still will spread rapidly as it has, because one person will spread it to much more than just another one person, but it'll go to 2 or 2.5 people. Next slide. And on this slide, we can get a picture of the severity, and I mentioned severity is really important. And so the severity is great for some people, but most people have a mild illness. And you can see from the part of this rectangle that is gray, 81% of people have a mild illness, and that's good. And unfortunately, then we have 14% who are severe, and then a much smaller percent, probably in the range of 4 or 5% or so, can be very severe and even die. So next slide. And the progression, you've probably heard about this already, but typically people will get infected, and there may be a few days between getting infected and then actually having the onset of symptoms. That ranges between about 2 days and maybe as many as 10 or 12 days. But typically they'll get an infection, then start having usually pretty mild symptoms, and we'll go into those symptoms in a little bit. And then hospital admission often will occur around the 7th day as they have increasing shortness of breath. And if they get worse, they can end up in an intensive care unit, get on a ventilator, and then either die or recover. Next slide. And here are some of the symptoms. You've probably heard these, and I actually have 2 slides that are a little bit different that illustrate these symptoms. The one that's probably most universal is fever and then dry cough. Those 2 occur in most cases, but not all. There are some people who have fever and then will have predominantly achiness and diarrhea, things like that. Also, not on this slide is the more recent recognition that there's a change in your ability to smell things. So a lot of people have had difficulty with the olfactory nerve. They're not able to smell things the way they normally would. Fatigue, shortness of breath. Shortness of breath is one of those symptoms that we really take seriously, because that can predict those people who are going to get into difficulty and need hospitalization or be on a ventilator. Other fairly common findings are muscle achiness, sore throat is pretty common, chills, nausea, and then diarrhea, which although on this slide it says 3%, probably a little bit more common than that. Next slide. And again, here's another illustration, slightly different than the one I just showed you, but it kind of shows you sort of how this progresses over time. And on this slide, they give a 22-day span for the illness. Probably some people are able to get through this in a lesser time. And we know there's actually a fair number of people who are fairly asymptomatic, who really don't even know that they were infected. The danger here is that they can be spreading this to others even though they don't have symptoms. And one of the things I didn't mention earlier was the reason we worry about organisms that come from other species, other animals, is that as humans, we may have no immunity to that organism. A lot of the diseases, illnesses that we get, we've seen them before. And so our immune system is able to react and then fight off the infection, and we do fine. But when a new illness occurs, a new disease, and it comes from another animal, another species, and we've never seen it before, it's kind of unpredictable what our immune reaction will be. And it sounds like some of the really severe illnesses where people are ending up dying or getting really, really sick, they actually, the response, the immune response, is a hyperimmune response that actually develops a lot of um, uh, factors that cause more difficulty for the person who's infected. Certain sort of toxic effects from our immune response is actually part of the problem. Next slide. So what do we do? Well, these are just some of the things, and I'll go through them really briefly, but hydration is very important. And hydration is important not just because we don't want you to get dehydrated, but it also helps to move the organism. If it does get into your mouth or nose and you swallow it, and then it can get into your stomach, and that's a much better place. We can kill it in our stomach. If it's in our nose, if it attaches to our nasal epithelium or to our trachea, then it likes that. It likes to be there, and it will proliferate. If we swallow it and it goes into our stomach, probably not as serious. Other things, Tylenol or acetaminophen for achiness is probably useful. Antivirals, those are just sort of being explored right now. We don't really know which, if any of these will be effective, but there's a lot of research being done. You may hear about chloroquine, an anti-malarial medication. Again, still some very early studies being done on it, anecdotal reports that it might work. But we don't know for sure. And sometimes taking a medication like chloroquine can actually make you sicker than the disease itself. So I think we would probably be very hesitant to recommend this at this point. Oxygen is a part of the treatment as people get sick and end up in the hospital. That helps to make sure that our blood is able to oxygenate and carry oxygen to all of our organs. Antibiotics, there are sometimes a need for antibiotics if there's a bacterial infection that complicates the viral infection. So in some cases, it's felt that some people will have the viral infection and get some problems in their lungs from that. But then on top of that, they'll get a bacterial infection, and the antibiotics are for that. There's been some question about what do people who are on ACE inhibitors do. The reason that's come up is that it appears that at least one of the ways that people get infected is that the virus may attach to parts of our tissues that are related to the ACE system, which we use for blood pressure. And at this point, there's really no recommendation for people to stop taking ACE inhibitors. Next slide. So there's a lot we don't know yet. For example, we don't know how effective the antibodies that we will probably, those of us who get infected and then recover, we don't really know how well those antibodies will work if we get infected again. And so what resistance will we have after infection? Really still not known. We also don't know why some people progress to severe disease. We know that there's certainly higher risk groups, older people, people with multiple chronic illnesses, but we don't know why they do it. We do know that it appears to be this inflammatory cascade that I was bringing up earlier, in which some of our own immune responses become very inflammatory to our lungs and maybe to other parts of our body. We also don't know about the sensitivity and specificity of the tests. So most tests, or virtually all tests, will have sensitivity and specificity. There'll be false positives, false negatives. And although we're developing tests, we really don't know how good those tests are going to be. And by the way, ASU is involved in developing tests. We actually have our first cadre of folks who are trying out that test today, actually. Dr. LeBaire is leading that effort. And we're hoping that we'll be able to make the test available to a lot of our ASU staff and students. But at this point, we're still kind of early and can't make an announcement as far as that goes yet. Testing has been a problem all over the country, as you've probably heard. And we need more tests because we need to know how the disease is spreading, who has it. people who are particularly in the health field, they need to know if they're infected and potentially are dangerous to others. We also want the antibody test to find out who's actually had it and might actually be immune. We don't know that yet. We also don't really know about the effects of public health measures on the spread of disease, or even some of the costs and benefits of the various measures that people are either currently doing or considering doing in the future. Some of our epidemiologists are hard at work on that, and I think we're continuing to encourage the various public health measures to try to reduce the spread. And we don't know whether this is going to go away soon or whether it will be with us in the future. There's some predictions that even if we are able to get rid of this in our population by April, May, well, we're up to April already, so May, June, July, that it could come back again in the fall. And so we may not be done with it, even if we're temporarily done with it. So these are just some of the things that are just answers we can't give you yet. So I'm going to end here, and hopefully we'll have some time for some discussion after everybody else has presented. So thanks for your attention, and stay healthy.
Thanks so much, Dr. Sklar. And next up is Dr. Matthew Scotch. Or Matthew Scotch is next. Not Dr. Doebbeling. There we go. Great, thank you.
There I am. All right. Can well, I guess, Scott, can you hear me all right?
Yes, sure can.
All right, great. Well, I thought Dr. Sklar did an excellent job in giving a sort of introduction on the clinical side of things. Whoops. There we go. And I'm going to give a little background on the sort of public health and surveillance side of things, including what's going on at ASU and biodesign. Some of it was already alluded to by Dr. Sklar. Next slide. All right, so some key concepts. Several of you that are on the call, I'm sure, are work in this field in epidemiology, so you can take some coffee during this time. But I'm gonna, for those that aren't as much familiar, I'm gonna go with some key concepts that are important for understanding when you hear things in the news about surveillance and epidemiology, exactly what those mean. Next slide. So epidemiology is the study of the distribution determinants of health-related states. Doesn't just have to be disease, but often it is, in specified populations. Next slide. So surveillance is actually the practice of ongoing systematic collection, analysis, and interpretation of data. So if you think about when you hear like cop shows, like I'm going to surveil a suspect, that's obviously a non-health related event, but sort of similar in terms of watching, trying to routinely get the latest data on the suspect, where they're going, who they're interacting with, who they're talking to, things like that. Same thing on the surveillance side with health. We're trying to always sort of come up with new ways to collect data that could be informative in terms of making decisions about what's going on in the community. Next slide. So a few ways that this is done, traditional ways that this is done is through passive reportable disease surveillance. So each state has a list of reportable diseases from the clinical side and the laboratory side. So if I go to the doctor and they suspect, for example, West Nile virus, they do some tests and those are sent to a lab, and the lab will do some tests, and then if it tests positive for West Nile, that'll be sent to the health department, and the clinician will also send clinical information to a health department, the local, and then potentially the state. And that gets sort of aggregated, and follow-up is done as necessary, and then aggregated to the US Centers for Disease Control and Prevention in Atlanta. But as we're seeing the last few years or so, with the ability to improve our computational efforts, sharing of data, field sequencing technology, we're able to incorporate new approaches into surveillance efforts, and these are helping greatly with our ability to track outbreaks. So a few of these I want to touch on is digital epidemiology, genomic epidemiology, and wastewater-based epidemiology. And these are actually things that I'm working on at ASU. And I'll talk a little bit more about that later. Next slide. So digital epidemiology is the use of digital data for epidemiologic purposes. The data might not have been generated for those purposes. So like, for example, news reports that can then be mined using machine learning and artificial intelligence or even human annotation and aggregated and presented in a way that allows us to track diseases. Social media as well. We think that when we're tweeting about something, we're not thinking that all of a sudden we could, that could be useful data for disease surveillance. We're seeing a lot of research that's being done, some of which funded by, for example, National Institutes of Health on use of social media for mining things from pharmacovigilance and adverse drug reactions to even infectious disease outbreaks. Of course, online news reports, even smartphone data. I know a lot of ASU researchers are looking at smartphone or using smartphone apps for various health-related activities, but then the use of that data to potentially be used for surveillance effort, additional online blogs and other web resources. Now, of course, with all this, there's issues with ethical uses and responsible use of this data, which are an ongoing concern. Next slide. So I'm sure many of you have seen this. This is actually from Johns Hopkins, colleague of mine, Lauren Gardner. I almost said Jennifer Gardner, the actress. Lauren Gardner, colleague of mine from Hopkins, started this. It's now morphed into the international resource that gets over 1 billion hits a day. And it's a really useful tool, sort of quintessential tool that's used this today for digital epidemiology for tracking SARS coronavirus. It has on the left the total confirmed by country. This is from last night, so my guess is we're closer. Are we over the 1 million mark for confirmed? Has anyone seen that? We're probably pretty close at this point. US, as you know, is now in, has the most cases, followed by Italy. And then you can get a nice view if you go down. If you see way at the bottom of this list, it says ADM 0. That's the country level. If you click on a specific country and then highlight ADM, click on the right arrow, brings you to ADM 1, which will be in the US states and Canada and other regions, provinces, so that you can then see how, what the total counts are for each of the states in that country. And then correspondingly, that'll change for the number of deaths and the number of recovered. Also show you on the bottom of that is the different links. For example, their article in Lancet Infectious Disease introducing the tool. There's a mobile version, and there's the list of data sources where the data are collected from. Some government and international agencies, WHO, World Health Organization, CDC, European agencies, NHC in UK, DXY in China, and all the others. And then next slide. So a little bit of their methodology, and this might have changed. I got this from the paper. Attempts to get, Lauren's been a little hard to, as you can imagine, been busy, so it's hard to get some responses back to her from her, but obviously understandable. But so it's a combination of text mining and manual annotation of news reports. Sort of, they describe it as a semi-automated living data stream strategy, where basically it started where they have she has PhD students that are scanning news reports or government agencies in, I assume in Mandarin Chinese originally, and trying to pull out key information. And then obviously as it expanded to multiple countries, doing that for multiple languages, then following up with authoritative sources to confirm, And then, of course, the geospatial mapping and graphing functions as well. My assumption is, as this is blown up, they've tried to automate this as much as possible using text mining and natural language processing. Next slide. So then the other type of epidemiology that we do in my lab, as well as what's been done by other excellent labs, notably NextStrain, which I'm going to talk about, is genomic epidemiology, where we're using virus sequences that have been generated for some of these cases to inform understanding on transmission and spread. The height of this was probably for the Ebola outbreak, where we were able to get about 5% of the cases. We're obviously under, well, not obviously, but we're less than 1% now, but we still have a lot. There's nearly 3,000 full genomes that have been sequenced already. And then using sciences like phylogenetics and phylogenetics, through the generation of sequences through next generation sequencing technology, we can understand a little bit more about evolution and spread, including localized transmission chains, as long as we have reliable sequence metadata. So what I mean by that is, do we have information about when the sample was collected? Do we have information about patient location? We don't need their address, but something like a city, a county, or a state is generally fine, so that we can look at how strains are diverging from one another and get a sense for transmission chains. Next slide. So there's a look at Trevor Bedford's tool at NextStrain. He's developed originally for flu. Some of you might have seen this. Trevor has also gained in a lot of popularity since this. He's Twitter followings now like over 150,000, which is 149,999 more than mine. Maybe 98, but it's pretty amazing. And most of it is through his excellent descriptions of the data so that he could communicate the findings to people that are less familiar with looking at phylogenetic trees. But he has an actual visualization suite there that allows you to basically transform the data into transmission chains as well. If we go to the next slide. Yeah, so you can run this video and get a sense for the different countries are related to the different region, color-coded regions. And then you can see at time elapsed, obviously starting in the purple in the Wuhan and China, and then looking at how that has evolved. I assume the circles represent the abundance of virus in that country at that specific time. Next slide. So what we have learned through genomic epidemiology so far is that we understand that this virus is from one introduction from an animal reservoir, as Dr. Sklar mentioned. We're not necessarily sure of the intermediate host. It likely originated from bats. That doesn't mean that the bat gave us directly this virus, that there's likely what we suspect is that it's from an intermediate host, potentially observed through the Wuhan fish market. It's not from fish. It could be from SARS, for example. We had potential being the civet and the raccoon dog, but it could be something sort of like that. Here, there's been no repeated introductions from animal hosts like we have from the Middle Eastern respiratory syndrome coronavirus, which is a related coronavirus, which is generally has repeated introductions from camels in the Middle East into humans. We don't see anything like that by in this case, because we're looking at the genetics and we see that there's basically not a lot of difference that we're seeing in terms of drastic changes in the virus genetics, like we would see if we saw repeated introductions from an animal host. We also know that this is a wild type virus, not engineered in a lab. We know this because there's only a certain amount of templates that can be ordered and then simulated through reverse genetics to a different strain. We would have been able to pick this up. We know that many of the genes are similar to genes that are found in the wild, and that the other mutations that we're seeing are mutations that we would expect from any sort of RNA virus at this point. So RNA viruses evolve at a faster rate of evolution than other viruses. And we know that because of their error-prone polymerase, that they're going to accumulate mutations at a generally faster rate. This is expected. And with this virus, we have seen that as expected. So we're not seeing any sort of drastic mutation that would necessarily increase its virulence that we would not normally expect at this point given a virus like that. There's some great publications below on this slide talking about that. I'll note the paper by Zhang and Holmes, and then paper by Nate Gruba talking about mutations of this type of virus, sort of eliminating the theory that we have two distinct strains of viruses at this point, a low strain and a highly pathogenic strain. Next slide. All right, so what's now the work that's being done at ASU? I'm going to talk about some of this. So the first is the wastewater-based epidemiology approach done led by myself, Rolf Halden, and Arvind Varsani. Looking for, we're starting this using Rolf's network of human health observatory wastewater samples that he's collected. We're going to start by looking at basically, can we detect SARS coronavirus in the wastewater? And there's already been some papers suggesting that as a possibility because you can shed the virus in feces. And then using appropriate metagenomics, we can detect the virus in wastewater and then look at the sequences. Then clinical surveillance from nasopharyngeal swabs of patients that present influenza-like illness. Myself, Brenda Hogue, a virologist at Biodesign, and Ephraim Lim, also a virologist at Biodesign, are working on that. And then, as Dr. Sklar mentioned, the testing that's being done at ASU Health Clinic, led by Josh Leber's Center for Personalized Diagnostics, and others as well. Next slide. So then quickly about our clinical surveillance study. And of course, I'd like to acknowledge the folks at ASU Health Service, Helen Sanderlini, Tony Denton, Sarah Finnerty, that have allowed us to participate in this and be so supportive of our research. This is part of a NIH-funded flu study that we have with Rolf and Arvind Varsani, where we basically do sample collections of nasopharyngeal swabs from the clinic every day. But as this SARS pandemic started to happen, we started to say, well, why, if we're getting the swabs, why don't we look for coronavirus in these swabs? Because you would test them in a similar way. It's an upper respiratory tract infection, and we can look for virus in nasopharyngeal swabs. So why don't we start doing that? So Ephraim developed a real-time RT-PCR assay based on recommendations from the CDC, targeting the NE and RNase-dependent polymerase genes. And he's basically made it fairly efficient where we can look at 48 samples in 4 hours. The process is below, where we collect from health services, respiratory, these are patients that present with ILI, and then they're collected swabs as part of routine clinical care. And we're using our influenza negatives from these to test for coronavirus. We could use the positives as well, but we're working off discretionary funds at this point. So we don't necessarily have the bandwidth at this point to test all of them. I should say.
Okay, I need to have you transition to Brad. Are you finished? Pretty close?
Yeah, sorry, quickly. Sorry, next slide. We do have some positives at this point. We've detected 5 positives recently from our RT-PCR assay that were collected during the week of March. And these are pending next generation sequencing. Also like to thank Arizona Department of Health Services for sending us one of their positives as well, which we'll be sequencing. Next slide. And that's it. Sorry about the length of time there. I happy to take questions after, but let's hear from Dr. Doebbeling.
Thank you.
Thanks. Hi, I'm Brad Doebbeling, and just going to talk a little bit about the impact of the public health measures and the outbreak on health systems and public health. Next slide. So there's a lot of exciting data available, and it's kind of hard to keep up with it, but I found this data from the Institute for Health Metrics and Evaluation at the University of Washington. Very nice, because it uses the most recent data to show projections, not only nationally, but also within Arizona. And you've probably been hearing that it's projected that the US epidemic's going to peak in around 14 days. You can see that this is using data on deaths that are occurring and data from the public health department. It's projected that we'll peak at around 25 days from now until the peak onset of daily cases. Next slide. So this just shows some of the impact of the resource use, which is expected to be at around 26 days, and also some of the impact on the use of different protective equipment, ICU beds, and so on, and the value of implementing measures to try and slow down and drop the peak of the epidemic. Next slide. This is from an informatics group that is working to develop terms and terminology that can be shared to help with modeling and information. And I posted a message from Preston, who is the lead in that organization. It's a not-for-profit called Leischow that's sharing health information and informatics tools using FHIR technology, FHIR. But this just shows the best estimate that we have of what happens with the onset of the different clinical symptoms from when they first start to become ill to start to develop the host inflammatory response. Next slide. So the CDC is the expert organization that we'd refer you to for information about risk assessment, and they're developing a framework for assessing and managing risk and implementing public health actions. This is obviously the lead organization for federal oversight, and state and local authorities have the right to implement measures based on what they see within their communities. This is varied a lot based on whether community spread has been seen. If there's not community spread, then just containment. But if there is community spread, then more active mitigation. Next slide. So community spread is really when there's sustained transmission. And part of the reason that Arizona just recently implemented stay-at-home measures was that there was not a lot of evidence of sustained transmission until recently. So it's unsure about when sustained transmission occurs, exactly how many cases are infected, and sustained transmission can occur even among people without international travel. Many have been infected with the virus and we just didn't know it. So the US has many states that have some community spread, and now Arizona Department of Health is saying that we do have widespread community spread within Arizona. Next slide. So if there's no community spread, the initial efforts are just containment. So we do things like Matt was talking about with surveillance, case finding, tracking contacts, trying to identify unrecognized cases, looking at international travelers and contacts of lab confirmed cases. So this allows some flexibility for prudently deploying resources. Next slide. Once there is community spread, which is where we are now, we're into mitigation. So we're trying to conserve resources, protective equipment, and also trying to, we basically have the same risk as people who are international travel because there are a number of cases around. So there's, it's not recommended that we have focused quarantine because it's ineffective, but efforts to community do containment is done it's really not feasible to try and identify all the cases, and often there's variation in how this is implemented based on political and ethical considerations of individual rights versus the public good. Next slide. So to summarize, when there are low numbers, we just focus on trying to containment, but it's really not possible to sustain this as the numbers grow. We're now into the mitigation phase in Arizona to try and slow the spread, reduce the surge in healthcare use so that we don't run out of necessary beds and ventilators and healthcare staff. We're trying to determine the right level of care. Many patients really require only self-quarantine unless they're very symptomatic and short of breath. We're expanding testing and hospital capacity and trying to tailor isolation. Next slide. So this is the data that's available on the Arizona Department of Health and Health Services. And as of yesterday, there were 1,413 cases in the state, 29 deaths, and it was considered widespread in the state. You can see a geographic distribution on the left, and then the number of cases by age group. Note that actually the largest number of cases is among those 20 to 44. This is partly related to more transmission and more testing in this population, but the more severe cases are still occurring in the older population. Next slide. There's also data from the COVID tracking project that lets you look at that kind of data, but state by state and nationally, which shows the testing that's happened. And this is the presentation from that site specifically for Arizona. You can see that our data is graded a quality B, and you can also get this data as a data set, either as a spreadsheet or via the API formatting. Next slide. So should we shelter in place? It's a mitigation strategy. Goals are to protect individuals at severe risk of illness and the healthcare force and critical infrastructure workforces. So this really emphasizes individual responsibility, focuses on settings that provide critical services, empowering businesses, schools, and community organizations, and minimizing disruptions to daily life. The goal is to flatten the curve. And there's currently a lot of discussion about, are we ready for a formal shelter in place with much stricter definitions of critical businesses.
Brad, sorry for interrupting. I've got 2 minutes left.
Sure. So the White House has shared this model to try and flatten the curve, to try and prevent full shutdown of the healthcare system. Next slide. The CDC has a number of guiding principles about when this should be applied. Next slide. Local hospitals have responded in varying ways, but they're limiting testing because we have limited tests available. They're starting to screen for fever before entry, cutting down on elective surgeries, no visitors, telehealth consults, and very conservative use of personal protection equipment. Next slide. So the community is responding through social distancing. There are a number of resources available through organizations like the JED Foundation, the American College of Lifestyle Medicine. The Calm app is available for free, and a number of yoga studios have made available their services for free. Next slide. Within ASU, there's been formation of a university-wide COVID-19 research working group to network faculty and respond to opportunities. There are identifying funding opportunities in the College of Health Solutions. We've created our own COVID translational team, and there are a number of other kind of innovative strategies for sharing data from CMS, Center for Medicare and Medicaid Services, There's a Google group that's sharing a lot of interoperability assets to figure out how to code data. Next slide. There is a knowledge enterprise health data working group that involves experts from across the university trying to figure out how to get better access to data and figure out how to prioritize research and pilot analyses. Next slide. And a number of resources here that I think you might find of use. So you'll be able to see these links, but these are some of the links that I gave or some of the links that have been mentioned to throughout the presentations. Thanks very much.
Wonderful. Thank you so much, Brad. So there are lots of questions, far more than we can get to in this time frame. We've started with, we got a list started, and what we'll do is we'll work to identify answers to questions that we can't get to. We'll create a website or something where those who are attending can access answers. But let's go ahead and Marcus, I think you got the first question.
Yes, thank you, Scott. So the first question that came up is, how would COVID-19 resurface in the fall if it goes away?
Well, I think I'll try that, but I think the way that it would resurface would be that there would be a small reservoir of people who would either come in to our area or you know, it would be continuing on at a very low level that we wouldn't really recognize, and then it would get into a population that hadn't, you know, wasn't immunized in any way, and then it would start to proliferate just as it has this time. So I think, you know, there's a lot of diseases that just kind of stay at a low level and then suddenly become epidemics based on a variety of factors. But I don't want to go into it too much because we don't have much time.
And if I could just add, there is the potential at some point it could become a seasonal coronavirus. There are already other seasonal coronaviruses out there that don't cause severe infection like this, so that eventually could be a possibility, sort of like what we have now with H1N1, which originated in 2009.
Thank you, Matthew and David. Are there any explanations behind why the United States has so many confirmed cases? And do we have more cases, or are we just testing more people?
Well, I think we do have more cases, sadly. And, you know, I think that we unfortunately fell behind in terms of doing the things that some other countries who were able to contain the epidemic more effectively were doing. And, you know, I don't want to get into politics, but let's just say that, you know, there were probably some things we could have done that we didn't do.
Okay. Is it possible that some type of acquired immunity protects against COVID-19? This may be pertinent in developing countries where people may be exposed to a larger variety of viruses.
I'll give that one to Matthew.
Yeah, I mean, I don't think we know enough yet. You know, that we're still sort of trying to figure out who's already been exposed. You know, they're collecting serum for potential antibody testing and things like that. But I think we're still sort of early in the stages to understand sort of, you know, and the problem is there's so many papers there. I saw one that said if you're O blood type, then it's a protective effect. You know, the problems here is these are all observational studies. We have to be careful with interpretation. So it's gonna, you know, we're not there yet in terms of definitive understanding of who has sort of the better protection and who doesn't.
Okay, a comment from a user. I saw that COVID-19 is sensitive to heat, specifically above 80 degrees Fahrenheit. Is that true? And if so, would Arizona be better suited to stemming the spread?
I don't think we know the answer to that yet. I mean, I think there's hope
I can
That's true.
I can jump in. There is a study that actually supported the fact that transmission seems to be less frequent, and with rising temperatures. So a lot of us have been hearing that in the news from the White House, but there is actually some evidence that that supports that from a small study done back east.
Okay. We have time for 2 more questions. If someone has a history of asthma or other related conditions, will more than self-quarantine be recommended?
Yeah, I'll just say a word about that. So I think one of the things we have to recognize is that when we touch our nose or our face in any way, that's really how this disease is spreading. And so people who have asthma or allergies or anything like that, every time they move their hands up to their face, they're increasing the risk. And that's one of the reasons they recommend that people wear masks. It's not necessarily that the mask is going to prevent the virus from getting into your throat or lungs, but that it keeps you from touching your face, your nose, and your mouth. And people with asthma and people with allergies, they are, because they're coughing a lot from their disease, do touch their face a lot. And so I think there is a risk. There probably also is a risk that people with chronic lung disease of any kind just have more inflammation going on. And we know that inflammation is part of the pathologic process here.
Thank you. And then our final question. The Centers for Disease Control and Prevention seems to be moving toward recommending that everyone uses some type of mask when in public places, such as grocery stores. Do you agree with that recommendation?
Yeah, I think I brought up the business of masks. I think the issue of masks is that it really does reduce your touching your face after you've touched something else. What we really all need to do is change our behavior. And I'm as bad as everybody. I mean, if you watch me on the screen, I probably touched my face about 20 times during this talk. So we're gonna have to change our habits in that regard. Wearing a mask out in public, that is one way to keep from touching your face. But there's right now culturally, people don't like seeing others with masks because they think that either they're infected or they're going to do something to them. So unlike some other countries, that's a cultural change that we're going to have to do. But I think that it probably does make some sense.
Brad or Matthew, any thoughts on that one?
Yeah, I mean, I think David said it pretty well in terms of the benefits of the mask.
Yeah,
there's discussion beginning among the experts that once we have enough masks to protect people at greatest risk, whether it will make sense to implement them in communities. And so you may see there's a hint of that going to happen, but we're still way too short on them now for that to be considered.
Great. Well, thank you very much, speakers, and also Marcus for managing the process, and thank all of you who have attended. We're planning on doing some additional COVID-specific health talks, so please watch your email for upcoming presentations. We're planning one on diagnostics, on diagnostic methodologies, and others. So please, if you have any particular topics that you think that we should be covering that you think are critical, please, you can send me an email or Marcus or any of the panelists, and we can use that to help our planning. So thank you all very much. Please be safe and distance yourselves, and thank you for attending. Appreciate it.
Yeah. Bye-bye, everybody.